This is a poster presentation for my study, Epidemiology of Helicobacter pylori in an underserved, uninsured population at an urban nonprofit clinic. My name is Staudinger Knoll, and I am a third-year medical student at the University of Arizona College of Medicine, Phoenix. This project was completed with the help of my mentor, Dr. Andrew Wong. As an introduction, the prevalence of Helicobacter pylori or H. pylori infection in the United States is dependent on a variety of factors, including socioeconomic status, race, and ethnicity. Higher prevalence rates are seen in low-income Black and white populations, people living close to the US-Mexico border, and immigrants from certain countries. The aim of this study was to determine the prevalence of H. pylori infection among the symptomatic patient population at an urban nonprofit, underserved, uninsured clinic in Phoenix, Arizona, and compare this to the pooled prevalence reported in the general population of the US, which is 35.6%. Our research question was, does the clinic population have a different prevalence of H. pylori than the prevalence reported in the general population, as this is an at-risk population? To answer this question, we completed a retrospective chart review that included 9,528 unique patient visits from February 2004 to December 2019. Of these unique patient visits, there were 628 total symptomatic patients for a total of 448 unique patients. Demographic information such as age, sex, ethnicity, and language spoken were collected. Patients under the age of 18 were excluded. Patient demographic and clinical characteristics were reported as means, standard deviations for continuous variables and frequencies, and percentages for categorical variables. The one sample z-test of proportions was used to compare the clinic's prevalence of H. pylori infection with the US prevalence. Subgroup analysis by patient characteristics was completed to ascertain if differences between the clinic and the US exist between groups. Logistic regression was used to ascertain associations between the patient's characteristics and H. pylori within the clinic setting only. All p-values were two-sided, and p less than 0.05 was considered statistically significant. Of the 448 unique patient test results, 193 were positive, giving us a prevalence of 43.1%. The average age was 52.1, 27.7% of patients were male, 96.7% identified as Hispanic, and 20.3% listed their preferred language as English. Using logistic regression, adjusting for all other variables within the model, there was an increased odds ratio of H. pylori infection with age 50 to 59, odds ratio 2.77, male sex, odds ratio 1.40, and Hispanic ethnicity, odds ratio 1.19, although none of these were statistically significant. Using negative binomial regression, there was a statistically significant increase in incidence rate ratio for Hispanic ethnicity, incidence rate ratio 907.7, age, incidence rate ratio 1.59, and English language preference, incidence rate ratio 32.7. Patient sex was not statistically significant. In conclusion, we found that the prevalence of H. pylori infection in our symptomatic patient population was 43.1%. This is higher than the pooled prevalence in the general population of the US, which is 35.6%, although it is unclear if this pooled prevalence is in symptomatic persons or the entire population. Statistically significant risk factors in our population include Hispanic ethnicity, English language preference, and age. Study limitations include analysis of symptomatic prevalence instead of true prevalence. Future directions include geographic mapping to find associations with prevalence data. I'd like to give a special thanks to my mentor, Dr. Andrew Wong, and Cheryl Soteros and John Jenkins at the Neighborhood Christian Clinic. I would also like to thank Paul Kang and Dr. Isan Shariari for their assistance with statistical analysis, and Kelly Howard for IRB assistance. Thank you.